Stress cardiomyopathy, also known as Takotsubo cardiomyopathy or broken heart syndrome, is a temporary heart condition that often mimics a heart attack but is triggered by severe emotional or physical stress rather than clogged arteries. Initial cases were described in elderly persons after sudden demise of their spouses. That's why the term broken heart syndrome came. Exact pathophysiology isn't fully understood but is widely believed to be caused by a catecholamine surge, that is, epinephrine and norepinephrine. This adrenaline storm can stun the myocardium, particularly at the apex of the left ventricle. The Takotsubo shape name comes from a Japanese octopus trap, which has a round bottom and a narrow neck. During an episode, the left ventricle balloons out at the bottom while the top stays narrow, creating a distinctive shape on echocardiogram. Patients may present with symptoms identical to an acute coronary syndrome with sudden intense chest pain. There could be shortness of breath or syncope. Because it looks so much like a heart attack, the diagnosis is often one of exclusion. ECG shows ST segment elevation or T wave inversion, which could be similar to a STEMI. Cardiac biomarkers, troponin levels are typically elevated, though often not as high as the degree of wall motion abnormality would suggest. Coronary angiography, crucially, this will show no significant coronary artery obstruction. Echocardiogram or ventriculography reveals the classic apical ballooning and reduced ejection fraction. There are other variants as well. Here is a comparison between stress cardiomyopathy and myocardial infarction. The trigger is intense emotional or physical stress in stress cardiomyopathy. In myocardial infarction, plaque rupture or blood clot, that is thrombus. Arteries are usually clean or non-obstructive in stress cardiomyopathy, while it is obstructed or blocked in myocardial infarction. Ventricular shape, apical ballooning in Takotsubo cardiomyopathy, regional wall motion abnormality matching a vascular territory in myocardial infarction. Recovery within days to weeks, usually full recovery in stress cardiomyopathy. In myocardial infarction, there could be permanent scarring or fibrosis. Acute phase management is mainly supportive with standard heart failure medications like ACE inhibitors, beta blockers and diuretics to reduce the workload of the heart. Most patients have a full recovery within 1 to 4 weeks, while generally benign complications like heart failure, arrhythmias or cardiogenic shock can occur in the acute stage. They can also have recurrence following another stressful episode.